Okay, I'm Di Riley, and I'm the Director for Clinical Outcomes with the National Cancer Intelligence Network. And as Ruth said, I'm going to try and do the impossible over the next hour and do some live demoing of the Cancer Commissioning Toolkit. The internet speed earlier on was okay. If not, we do have Plan B, and I can go back to good old PowerPoint. Can I just check who might be going onto the toolkit at the same time as me? Have you got anybody? One couple of tables? Okay, right. So it feels like, the others saw it, it's a bit like being in front of the Gestapo here. There's a spotlight right here. So actually I can't see many of you, which for you is probably a good thing. Okay, I want to do two things. I want to start off talking a little bit about information and data to support commissioning. So we're not going to do the live demo just yet. I'm going to keep delaying it as long as I can. It worked well in London last week. It didn't work at all in Leeds. So, you know, there's a 50-50 chance it'll work today. But let's talk a bit about information and data to support commissioning, because we're moving into a new world really across the NHS, and since 2007-8 there's been a real focus on having good evidence to support and really understand our services, which I think before then those of us that were in the ANARAC camp were very much saying, let's use the data we've got out here, let's really understand what's happening with our services. But we were still, I think, several years ago in that sort of anecdotal world of we thought we knew what was happening, but we didn't really look at the data in a lot of detail. These are the NCIN core objectives, and what I'm going to share with you today is really the work of an awful lot of other people, both within the NCIN, across all the networks, across the services, both primary, secondary, tertiary care, and colleagues in the national team. I get to do the nice bits really, they do all the legwork. What I'd also like to say is that for NCIN, the first N stands for national. Most of our work is around England, but national for us also means the whole of the UK. So a lot of the data that you'll be able to access that NCIN is pushing out covers the other 3 devolved nations as well within the UK. And the second N is network, and we have a small core team based in London, but we very much work with all the different cancer registries, lots of academic groups, and the cancer networks, and everybody across the NHS. So it's not just 20 or so of us that are based in London. These are our 5 core objectives that Jane put up earlier, and very much our vision when we were asked to set up this organisation in 2007-8 was around really bringing cancer informatics to the fore and really looking for good evidence and pulling together and signposting what data are available to you all. So it's very much, in our mind, sort of an end-to-end pathway for cancer data. And some of you, I know, will love getting your hands dirty with this stuff. Some of you will rely on other people to do it for you, and some of you may still think, I really don't know quite where to start. So I'll try and sort of take you through some of that and some of the issues that we face. So I think the role of NCIN is very much about understanding your requirements and delivering that information to you. If we get it right, we are very much the silent service, if you like. We are just pushing out to you what you need and providing that intelligence. But I think what we're all aware is how quickly the NHS changes and that there are different needs for different people at different times. And one of our challenges is being really flexible. We had the question asked about looking at CCGs. What we need to be able to do is to move very quickly from PCTs to CCGs when they come in, but understand those different geographical boundaries and the implications of it. The challenge for all of us, though, is that we can only be sure to improve what we can actually measure, and that's a real challenge. And when the 2 nice quality standards came out for breast and colorectal, and Andy and I were involved with developing the service profiles, we went through them both with a view to saying, let's include all of these. And some of them were almost impossible for us to look at and analyse nationally, because you were looking for groups and subgroups of patients within the total cohorts. So just be warned if you're involved in some of these groups that are looking at indicators and metrics, and what you might want to look at locally is do we actually have the data available to us? Can we identify that subgroup of patients? And can we actually then do anything with that data? Oh gosh, sorry, that was a bit horrendous. Okay, we've heard some of the key messages from the team at Cancer Action Team around we're really looking to save lives, provide value for money, and improve the quality of life and experience of care for the patients and the public. So to do that, not just do we need to understand the requirements of the population that we're going to commission services on behalf of or represent, but we also need to understand the flip side of what's actually happening in our services, and they may be different analyses in different groups of patients. We need to understand what the patients want. I think all of us, if we were patients, will say we want to be treated close to home. If it was something very serious, we might be prepared to travel wherever in the country to get that treatment, but we also always want the specialist. So most of us, if we were thinking very selfishly about ourselves, will want the specialist close to home, and that's the real balance that we have to work out in the NHS. How do we do that? And to do that, we have to understand how much it costs, where can we make changes, where can we ensure we're providing value for money, where do we need to disinvest to reinvest elsewhere. I think we're not naive enough to think that there's lots of money out there that we can just bring more money into the service. So it's how do we move it around between different services, which may not always be between cancer services. So this slide, those of you that have been around probably as long as I have or longer, when we were first putting the toolkit together, will remember this slide around some of the important metrics that commissioners back in 2007 and 8 were grappling with when they were looking at laying the contracts and understanding commissioning for cancer. And when you talk to commissioners, as we were then and we continue to do now, they were telling us that they may only have 2 or 3 days in a year to focus on cancer. So what's key is that we know what are the real messages we need to be getting out there and how do we present it. Because I think even for those that are very analytical aware, there is so much data out there, it's key that we target the right bit of information and not ask people to go all over the place to try and find it. So, okay, let's look first at what do we know or have access to from existing data. And what I want to do now is just sort of show you different bits of data that are out there along different parts of the cancer pathway. This is by no means everything that you can access, and I'll tell you where a lot of this data are, because what you'll see is that some of it's in peer-reviewed papers, some of it's on the NCIN website, some of it's not published, and it can be a real challenge, even for those that know where to find the data, to get hold of some of this. So these are some of the questions if we're thinking around how do we save these 5,000 or 10,000 lives, what do we know about our population, where do we find some of this information? The slide at the bottom, which is showing you the increase in incidence, which is the top line, and the reduction in mortality, looking at all cancers. This is data that you'll find on the CR UK website, but you'd find very similar information on the NCIN website or the UK Cancer Intelligence, the e-Atlas, sorry, or the UK CIS system, which is within the NHS. So there's 4 or 5 places, if not more, that you can go and get this information. And what you might find is that depending on what year they're looking at, you may get different answers. And that's a real, the answers won't vary hugely, but they may be subtly different depending on where the source data's come from. Ruth showed a variant of this slide, again looking at UK outcomes. We're all focusing very much on how do we bring the UK up to be average or better than average. This is data that was published in the Lancet. Again, some of you may be able to access this data directly, and some of you may not, but we all know it's out there. What we've also then done when they started to work out how did we get to those 5,000 or 10,000 lives, there was then work done across some of the NCIN organisations, because networks were coming to us saying, okay, we know that this is going to roughly represent 40 to 60 patients for our network or more. But how do we break it down by different cancer sites? So what we then did was worked it out on a sort of proportional basis. Now this information, apart from probably appearing in lots of these presentations and us sending it to various people, again, if you went looking for it, you may not find it. I don't think it appears openly on our website other than in presentations. So again, key bit of information for a lot of people, but maybe difficult to find. The other question that's being asked is why, and this is a lot of the focus around the NADI agenda, is why is our survival poorer in the UK? And one of the views is that we present late, that our stage, we're presenting at a stage which is less amenable to treatment, and therefore we die earlier. But our staging data is poor, so Ruth, I think, mentioned, several of my colleagues have mentioned the importance of staging data. There's a real focus now, both from the registries and to the providers, around capturing that information as patients go through the service. But what this slide is showing, if you look at the first slide, again, this is something that an article that appeared in the British Journal of Cancer. Some of you may be familiar with it, some of you may never have seen it before, but it's quite illuminating to me. It's looking at 2 follow-up intervals by age, patients diagnosed who die within the first month following diagnosis, and what happens post that 1 month. And the age groups are along the bottom. And what you can see, that patients diagnosed over the age of 70, far greater proportion die within that first month than elsewhere, than Norway and Sweden. If patients live beyond that month, then their 1 year survivals are probably very comparable to the rest. So it's trying to understand what's actually happening here with the elderly population, and looking at different lengths of period of survival when you're fast, those patients that die very quickly. But again, a piece of information that some of you may be familiar with, others of you may not. We've also talked about routes to diagnosis, and I'm not sure whether one of my colleagues put a slide up, but showing that around a quarter of our patients are first diagnosed with cancer coming through as an emergency route. We know these are often elderly patients, and they're often from cancer groups like pancreatic, brain tumours, where the symptoms are often very difficult for primary care to identify. But this information hasn't yet been published. Again, we're putting it out through peer-reviewed papers. It's probably the worst kept secret of any of the data at NCIN. But outside of going through the commissioning toolkit, again, very hard to get hold of this data and actually start to look at it for your local populations. We've also looked at, Jane mentioned about transforming inpatients, and we're beginning to do a lot of work around resection rates. And this was an article that appeared in the Times last year, some of you might have seen, where our analysts just looked at surgical rates by age by different cancer sites. Again, this is on, I think on the NCIN website. This is a PDF that you can download and look at this data. And I think one of the things that we've probably been poor about is actually signposting and sending this information out to a lot of you. When you look at the actual article, what you see, this is by age. Again, huge drop-off in resection rates as patients get older. Now, this hasn't been adjusted for age, has been adjusted for age, hasn't been adjusted for comorbidity or stage, and it may well be that actually there's very valid reasons for this. But when you look at it on the face of it, we need to understand that and be able to case mix adjust some of that data to really understand what is happening, and to understand locally, do we see the same scenarios as we're seeing here. And then we can get into much more detail about outcomes varying between hospitals. This is looking at 30-day post-op mortality. This is for colorectal. Some of you might have seen this when it came out a year ago. I think it's about to be republished, using approaches like this funnel plot. Now, some of you, again, will be very comfortable looking at these. Others of you will think, I really don't know what this is about. In effect, what it's showing is that each of these black dots is a trust in a cancer network, is a trust providing colorectal services, and if they're within these upper and lower 95% confidence interval, 2 standard deviations from the mean, then there is no difference between what is happening in their 30-day mortality between those trusts. But any trust that appears out here, and there are 5, have a higher than expected 30-day mortality, and there's 3 or 4 where the 30-day mortality is lower than expected. So we have outliers, some you could say good outliers, some are perceived as bad outliers. Again, this is data that appeared in GUT. Again, some of you may have seen it, and again, some of you may not. And I think the challenge for us is, how do we share this information with you and get it back to the right people in the right format? And Andy, I think, or Jane, showed data from the patient experience survey, looking at how patients feel about their care, and showed how the trusts were colour-coded. So if the answers were in the top or bottom 20%, they were coloured red or green. And if you were a patient looking at this, this is probably one of the few sets of data I've shown you that are actually out in the public domain. If you were looking for an MDT to go to, if you were looking at one of those trusts that was predominantly red, you may be saying to your GP, tell me a bit more about those hospitals because I may not want to go there. So this is all the information I know you're having to grapple with, whether it's within the commissioning groups, the cancer networks, commissioning board, SSGs, etc. So there's lots of areas that we know can make a difference, and I think the challenge for all of us here is how do we pull that data together and look at all those metrics in sort of triangulate them one against the other, look at them in a sort of 3D type approach, because each one of what I've shown you are independent analyses, and I think the trick for all of you and for us is bringing it then together. You know, what happens if you change one indicator, does it affect another? So there's a load of information out there. It's in loads of different places and it's loads of different formats. And one of the questions for you is, ask questions at any time, but you know, how can we share this information with you better? So how do we communicate it to you? I've touched briefly on some of this, and if you go onto the NCIN website, one of the rationales really for us setting up was not just about making sure that we were undertaking a lot more of the analysis and making the understanding of the services much more evidence-based, but also to be able to signpost people to the right information. And I think there's a real danger as we do more and more of these detailed analysis that we can actually confuse the landscape even more. Because we're producing data briefings, PDF documents, interactive Excel spreadsheets, there's a number of e-atlases out there. And I think the challenge for NCIN going forward is to really listen to yourselves to say, what do you want? Do you want one place where you know that's where we should go to, or do you want somewhere where actually you can come into our website and be signposted to the right place to go? Because I think otherwise there's a real danger that we'll still all be sitting there saying, I know the data's there, but I don't know where to find it. So the question that we then came up with was around, do we want this one-stop solution for accessing data for cancer commissioning to help support that decision making? Well, we've had a number of, if you like, sound bites around the commissioning toolkit, and I know lots of you have been using it. So again, I think there's two things happening here. One is around the role of NCIN and bringing a lot of this detailed information together or signposting it, and then there's what do we need to bring together to support the real commissioning agenda. But there are challenges, and a few of these have been alluded to, and in discussions with a number of you, I know we're often coming from the same place on this one. And I hope that's not my phone going off. No, it's not. An awful feeling I haven't switched it off. Andy's already shown you the profiles, and I'll show you in a minute the GP practice profiles and some of the other things that are in the toolkit. But I think from where we're sitting, we need to help you understand the cancer burden. What does the population look like that we need to be commissioning services for? How many, how old, how young? What other things do we need to be taken into account around deprivation, ethnic mix, etc.? And then we need to understand our local services, which is where our GP profiles or CCG profiles, when those groups start to come on board, and the service profiles will start to help us. We also want to look at providing benchmarked information. How do we compare? Now, most of us get very nervous when we start seeing the concept of benchmarking and log tables and looking at outliers. But actually, there is something about understanding where your service sits in relation to others and looking at those different indicators together. And being able to pull out how do we sit against key performance and quality indicators. Most of them have been put together by clinical groups and commissioners and those that really understand the service. And if that's what they're saying is this is what a good service should look like, then I think we should do our best to try and turn that back and say, and this is actually what they do look like. But I think there's too about what's the role for groups like NCIN with some of the commissioning support services, with the cancer or the new clinical networks, your local cancer networks, and the CCGs. And what information do we need to target for those different sorts of levels? Because I think it would probably be wrong to be forcing a lot of information into the CCGs when actually it's probably the networks that will still be doing a lot of that guiding. But the real issues, I think, are on this slide. And the first bit really is around the timeliness and quality of the data that we can provide you. Now, many of you will have worked with your registries over the last few years and seen that, you know, incidence and mortality, although it's changing, it doesn't change hugely year on year. So if we're looking at incidence and mortality data that's 2 or 3 years old, or maybe 4 years old, that is probably okay. It's very robust and it's not liable to change too much year on year. But if you want to look at things like certain surgical procedures, the overnight breast model or laparoscopic colorectal procedures, then looking at data that is 3 years old won't give you an up-to-date view of what's happening in your local services. And if we share that sort of information back with clinicians that's 3 years old, they just will put it in the bin, tell us that the data's rubbish, that either services have changed or they weren't in post anyway when that data was derived. So we're in between a rock and a hard place on a lot of this, between wanting to provide very good, robust, reliable data, but at the same time recognising that there's a difference between sort of peer-reviewed academic type papers and the world most of you are living in, where you want to know what happened last week. I can probably get away with a year 18 months ago or a year ago, but I can't get away with 2 or 3 years. So we have to look at where we make those value judgments and which data source we use and how timely we can use it. Are we collecting and reporting the right data? Is it specific enough? And we had a question around the toolkit the other day about the inclusion of some of the non-invasive cancers. Because as a commissioner, you might be commissioning a service that includes all patients, irrespective of whether that condition is an invasive or a non-invasive cancer. You might not want to separate them out, or you might want to see them as 2 separate cohorts. So we're always caught again between when do we put patient groups in or when do we leave them out. We also get the feeling, although this doesn't seem to have been borne out through these roadshows, that everybody, whether they're charities, the colleges, some of the other organisations, are producing commissioning support, because everyone wants to make sure that their voice, much as we are too, is heard out with the commissioners. And we will start to see a whole plethora, I think, of dashboards and profiles coming out. So again, I think we need to be guided by yourselves. If there is too much out there, how do we pull that back? How do we work together with some of the other organisations to make sure you get the best that's out there, rather than confusing the landscape further? And lastly, Jane touched on this, and you did the exercise with the breast pathway, which is probably one of the more simple pathways that we would contract or commission for, that there may be different groups commissioning different parts of the pathway. So again, a real challenge for us of, do we look at the pathway as a whole? Do we start to chunk it up for the different commissioners? And just looking along the bottom there, you know, some of them we know will be commissioned by the commissioning groups, whereas others will be commissioned by the commissioning board or the specialised commissioners. So it's really difficult, and if we think that radiotherapy is going to be commissioned at the national level, they may not be looking at it at individual cancer site, they may just be looking at it as radiotherapy as a whole. So again, if you're looking at a breast service, we have to work out whether we're able to pull the data for breast out of the big radiotherapy pot, if you like. Do we need to? Is it relevant? So we have to ask all these questions. So anything, feedback you can give us will be really, really appreciated. Okay, I think I've thrown out a lot of these questions, so I'll move on from this slide. It's not that I don't want to answer the questions, but if perhaps we go into I think the toolkit comes next. I've delayed it probably as long as I can. Then start to ask some of those questions as we go through. And I think the questions for us are around, how detailed do you want us to go? You know, do you really want us to get down to very small numbers, but very detailed ICD-10 codes, if you like? You know, splitting out all the urology into the different groups, or the gynae into the different groups? Or would you be commissioning at gynae level per se? Or do you actually see cancer as part of the wider NHS, and therefore if you're commissioning breast services, it doesn't actually matter whether patients have got an invasive breast cancer, DCIS, or they're actually coming in for real benign breast surgery? Do you want a one-stop shop for cancer data? I'm going to show you one that we've been developing over a number of years. What do you think of these profiles that Andy showed you? And do you think these profiles should go wider than just the part of the service we're showing at the minute and include the whole of the pathway, even if some of those parts of the pathway, like radiotherapy and maybe chemotherapy, will be commissioned at a more national level? Okay, now let's see if this is actually going to work and go into the commissioning toolkit. I've got a few PowerPoint slides first. The URL you can see on there is for the commissioning toolkit, and those of you that don't already have access to it, I would suggest when you get back to the office to go on and register. For all of you with NHS contracts, you'll be able to get in and register very easily. For those of you that may be part of some of the new commissioning support groups that don't have NHS email addresses, go on to register. We'll be able to pick you out and put you in as a named patient basis. And those of you from primary care, I think we need approval from one of the senior members of the primary care team, and then anybody can have access in. I'm looking at Cass Yates, who's our programme manager for this. Have I got that all right, Cass? Yep, excellent. Okay, so what we tried to do back in 2007-8 was to bring together all these different sources of cancer data into one place to provide the Commissioner, as they were then, and we've begun to change it for the evolving landscape, bring that information together into one place and really share with you what the Commissioners and the networks then felt was important for understanding local services. And we were working very much now along the lines of we saw in the Improving Outcome Strategy, again the mention of NCI and NCAT producing this commissioning support pack. And it's a three-way support pack with the key messages that Ruth talked about, and the service specifications and the service profiles that Andy talked about. And all of these, you can find everything to do with this within the commissioning toolkit. So if you're looking for these, you will find them in there, and as we update them or add more, they will go straight into the toolkit. So this is what we'll see when we go in, and I promise we will go in a minute. And when you go in now, those of you that haven't been in for a while, you'll see that the whole format of it has changed, and there are 4 key areas. And what I want to try and do in this demo is to quickly just run ourselves through these 4 areas. One is around what's in there around key messages, look at the service specifications, or show you where they are, look at the 2 profiles that we've currently got in there, and then show you some of the more interactive charts where you can start to look at data in a bit more detail. Right, let's see if this is going to work. I've probably been logged out. I thought I might have done. See, I've got dyslexic fingers now. Don't know quite why I've been logged out of this. Why does this always work? It works beautifully sitting down there. Right, for those of you that aren't yet registered on here, you'll see at the bottom on the right-hand side, it's got a not yet registered, or not registered yet, and that's where you go in and type in your information. What have I done wrong? Cass, you might have to give me another one in a minute. Right. When you first get in, you will see there is a disclaimer. We've started calling this the sort of the Daily Mail disclaimer. A lot of the information in here does get down to very low cell counts and could be construed potentially disclosive. So at the minute, if you're going in through this route, then you are asked every time to accept the disclaimer. We are looking at how much of the information in here we can put out into the public domain. So there will be, there is already a charity commissioning access for those people outside the NHS, but we're looking to see how much we can put into the public domain later on in the summer. So this is the 4 key areas that I mentioned to you. Key messages. God, it's a bit sensitive. It wasn't what I was expecting to happen. Okay, when you go into the key messages, it comes up with these 3 different boxes, and if you click on any one of them, it will download the relevant documents for you. So you can either just go in here and check whether they've been updated, or just download them and have access to them. So this is the basis of the paper that Ruth was talking about around what are the key messages for commissioners. There's also the Cancer Commissioning Guidance, which Jane talked about. Again, this is an interactive PDF. It's about 150 odd or more pages long. But once you're in there, if you're used to using interactive PDFs, you can go in and look for particular services, and it will show you the questions that you may need to be asking of your service. The other document that's in here is around user involvement in commissioning, and this is an article that, or a PDF that's been put together by the Cancer Action Team with Macmillan around how you might want to involve your users in supporting your cancer commissioning agendas. So those documents are all in the toolkit. Hopefully I'm not going to close it down. Okay, if we now go into the service specifications, so if you think of that three-pronged sort of approach, this is now where you will find the service specifications. There are 3 in there at the minute, the breast and colorectal ones that Andy mentioned, and one for radiotherapy. And as more and more get signed off, they will all be put in here. And the toolkit gets upgraded or updated 4 times a year. So at the end of each quarter, the next release will be at the end of June, and we send out to all those of you who are users an update newsletter, if you like, that says this is what's new in the toolkit this month. So as we put new service specifications in, you will automatically be alerted that those are in there. And then again, you can just download them and either save them to your hard drive or, oop, what's happened there? And this is what they look like, for those of you that haven't seen them. I won't go into it in any detail, but it covers everything that Andy was talking about. Now I'm in danger of closing it all down. Okay, so the third part of this then was the profiles of what does the service look like in relation to the specification that's been put out. Now, I think this is a bit of a misnomer actually just calling it profiles, because in this section there are an awful lot of other bits of information that people might want access to. So before I go into the profiles, I'll just take you through what's in the other 2 parts of this section. One is called data extracts, and under here, what we've started doing in the toolkit is where either our NCI analysts or other analytical teams that we work with have been producing data that we want to share with you, but actually is at a stage where either some of the methodology is still being explored further, or we don't feel this is data that can go openly onto the NCI website. We are putting this information into the commissioning toolkit. So there's stuff in there now around hospital episode statistics at SHA, PCT, network and trust level. So these are mainly around length of stay, admission types. And those are in there and they're updated every quarter, and I think it's on a rolling year. So you can actually go and see what's happening over time for these different levels of organisations. There's also information about laparoscopic resections, the LAPCO work, again I think that's at provider level, and work around radiotherapy fractions and for different cancer sites. I think we've just got 4 in there at the minute: breast, colorectal, lung, and I can't remember the other one. What's the other one, Cass? Gynae. But again, you can go in there, and I think you can split it out by the different cancer trusts. And the routes to diagnosis. There's a big interactive PDF in here, 4 routes to diagnosis. I'll see if it will download. This is the sort of thing you'll get to where it will tell you a bit more about it, what's in there, and there's yet another sort of Daily Mail reminder box here, just to be saying, if you take this data out of it, you have to act accordingly with the governance rules that we're giving it to you. This will run. There we go. When you download this Excel file, you'll see that there's a bit of introduction, but then it will show you the different types of routes to diagnosis at England level, their 1-year survivals for those patients, looking at it by sex, age, deprivation, and you can start to get into looking at it for your cancer networks as well. So there's an awful lot of information in there for you to go and access, and we're using the toolkit as the vehicle for sharing this with you. Because it's not yet out in the public domain. Okay, let's go back into the profile section. Also in there, you'll see it's got a section called PDF reports, and again, this is information that has come from different reviews or surveys that our colleagues have worked on. There's one that the CNS, Cancer Nurse Specialists, have been doing, looking at workload, whole time equivalent by cancer network, by different cancer sites. So although this is probably available outside of the toolkit, we've also put it in here for the sake of completeness, so you can go in there and download that. And then there is a quarterly report that we're putting together, and if we get time I'll show you a bit more of it, around radiotherapy. And this is a report that we were asked to produce for the National Radiotherapy Implementation Group, who wanted to keep a handle on how we were doing nationally against the standards that were proposed in the implementation group for radiotherapy, so around fractions per million, age of linacs, that sort of thing. And we decided that rather than just produce it quarterly for them, if we put it in here, then it enables you to pick that up as well. The toolkit has, you can then delve down into your different organisations, but this PDF report is at the national level and has a clinical commentary on it each quarter to say, oh, how are we progressing against some of those national standards. Okay, now let's sort of drop into the profiles briefly and just show you sort of how to use them if you're not familiar with them. A bit more sort of the next stage on from really what Andy showed you. So there's 3 sets of profiles in there at the minute. There's the GP practice profiles that I know many of you have seen, and I'll go into one of those in a minute. Profiles at PCT level, and then the service profiles which have both breast and colorectal in them. If we go into the GP ones, and I'm not going to download it at this point, you'll see that there's now 2 years worth of data in here, 2010 and 2011, and they're grouped at PCT level at the minute. So what you can do is go and download all the profiles for your particular PCT. The reason it's not England together is purely that Excel can't actually handle the size of 8,500 profiles in one place. Once we can build them slightly differently, you'll see you'll be able to pick out all 8,500 in one go. If you want the whole lot, you've got to download 152 Excel files. But what you'll see is you can either download the Excel files or you can actually download them already as PDFs, which I know quite a lot of the primary care leads have been doing, and then taking them out into the practices to discuss with the individual practices what those profiles are showing. And underneath it, you'll see there's a number of documents, again, guidance around what are these profiles about and how do you actually use them. So if I just go into, this is the set of profiles for Bristol that I downloaded earlier. But what you can see up there, again, you may not be able to read it in detail, but feel free to come and have a look at lunchtime, is, again, it's the format that Andy showed you with this spine chart, and the coloured dots represent where that practice actually sits against its peers within the PCT. And then at the top here, you can change and pick different practices. So if I just pick on a few practices at random, you'll see the coloured dots start to move and change. And what's interesting when you start to look at some of these profiles is the impact of one metric on another. And when we looked at these for the practice where I'm registered, we noticed that the numbers of 2-week wait referrals for breast and skin were very, very low compared to the population that practice serves. But what we also realised was that the screening van was in the area for that time period, so a lot of patients may have been going to screening rather than coming into primary care. And we also have a GP with a special interest in dermatology. So again, there were a lot of patients that were being dealt with internally with the practice rather than going into secondary care. But it's often by looking at those indicators together that you start to get the real picture of what's happening. Okay, let's go back to the toolkit. And then we have the service profiles, I hope. I've lost it. Okay, not to worry, because here's one I made earlier. So this is, again, the practice this is the breast profile rather than the colorectal one that Andy showed you. But again, it's the same approach of being able to download an Excel file that has all 165 breast MDTs contained within it. And again, by selecting a particular trust, I'll show you the spine charts. It will vary. They will start to move around. Now, we tested this with all the MDTs before Christmas because we were very aware that this was probably the first time, from a service perspective, that we'd brought together point estimates, if you like, from about a dozen different data sources. So although the toolkit was bringing data together in one place, each different data source was didactic, if you like. You could go and look at cancer weights, you could look at screening, you could look at incidence, mortality and survival, you could look at program budgeting, but you couldn't see them all together. And what this does is bring out a point estimate, if you like, for a number of those indicators. So we tested it for a month across the service because we wanted the clinical teams to understand where this was coming from, understand the approach, and to really look at the methodology that our analytical teams were using and to comment on that, because what we certainly didn't want to do was to alienate 165 MDTs overnight, really, by putting these profiles out even across the NHS. And we had a number of comments back from a number of trusts, and hopefully this will work. So what we gave trusts the opportunity was where they saw there were some real problems with their data, and I'll show you, hopefully this one will come up. We gave them the opportunity to comment. So whilst we couldn't go back and change the data for that trust, and often it was around the HES data, where there were issues around coding. Sometimes they knew they had issues about coding and sometimes they didn't. So they were either asking us to pull the data out, they were asking us to change the data, and we said, well, we actually can't do that because this is what is nationally available and actually is looked at by all sorts of people. We need to be sure we're showing comparable data here. But what we can do is put a comment in to draw attention to whoever is looking at that profile to indicate that there's an issue for that particular service. The one I'm showing you here is the Isle of Wight, that has a breast service that's actually run through the PCT rather than through a provider organisation. The analysts just hadn't realised that and hadn't picked up the Isle of Wight PCT in this analysis. So we saw it very quickly because the length of stay for this particular clinical team was 0. So the commissioners were quite happy, but actually the clinical team was saying something wrong here. So it had a big impact on quite a few of the indicators. So we gave them the option to go in and put their own comments on it. Okay, let's see if we can get back into the toolkit. And I'll show you some of the more detailed data that's in here. Okay, so those of you that were familiar with the old toolkit, and I know there's quite a few people in here who were, this section here called charts, up at the top there, is where you will find all the old data that you used to see before. So if we go and look at, I don't know, somebody give me some, where does somebody go in regularly into the toolkit? Rather than, let me go completely off-piste here. Anybody go into something particular? No? If not, okay. You've lost your chance. Okay, when you click on any one of those tabs, it will open out and show you all the different reports or charts that are actually inside the toolkit already. It will tell you what they're called, and it will give you a bit of a summary about what's contained in this section. So in here, again, you can see that there's a lot. So here's the NRIG report. I'll show it to you in the PowerPoint in a minute rather than going into it in here. The service specification, so wherever you are in the toolkit now, it should be pulling together the different bits of information you need. And then you can start to see different charts around attendance per million, numbers of LINACs per million, numbers of LINACs per million over time. Because again, we found it was important that not only could you see information benchmarked against your colleagues, but also your own service over a number of time periods. So as new data becomes available, we added in and increased the trend charts. Cancer weights, age profiles of LINACs, cost profiles per attendance, peer review, and patient experience survey. Oops. So if I just go into one of them, so I've now gone into the age profile of the LINACs, and this is showing you all the different LINACs across the whole country. But actually, if we scroll across to the right, you can start to see that you get different options as to how you can start to cut that data. Now, what this chart is showing is the age of a LINAC and how many we have in the country at a particular age. And the graph is coloured pink from this side, so this represents any LINAC that's over 8 years old. And my understanding is that once machines get to that sort of age, then you really need to be putting in the business cases of how we're going to renew and replace those LINACs over the next few years. So what you're looking for really is LINACs over this side, which are the newer ones. But you can look at individual networks. Let's pick one a long way from here. Oops. We can ask to see what's happening in Yorkshire. And it will show you how the 10 LINACs that they've got out there, 8 of them are 5 years old and 2 of them are 7 years old. And you see different profiles if you pick out different networks. This is South East London. And you can also just pull it out by individual trust as well. So if we just looked at Cambridge, because in some networks there's more than one provider of radiotherapy services. If I go into one of the other charts, you'll start to see that there are other breakdowns that you can look at. So this is cancer waits, 31 days, again by a provider, showing you the national standards. So wherever we can, we're showing you what the standard is. And then you can start to highlight different organisations. I'll just pick out 3. And it will show you where those trusts sit on that benchmark line. Now what you can also then do is actually set these up as favourites. So if you're in a particular part of the world and you always want to see the same PCTs or the same networks or the same providers, you can set them up in your favourites, and every time you pull up a chart it will show you where that organisation actually sits. We can also look at different cancer areas, so we could just ask for breast. And it's recalculated it for us. And we could look at different quarters. So again, you can go in and you can just change and look at different things over time. And you just see the lines changing. What time do we need to finish, Ruth? Because I could stand up here forever going through things and then realise everyone's asleep and miss lunch. Okay. Okay, rather than, I could go in and out and find lots of different things, but if I go back now to the PowerPoint and just scroll through to the end, and then I'll open it up for people to ask questions. I showed you in the profile section this bit about PDF reports. What I just want to show you is this new radiotherapy report that we've produced. And this is basically what it looks like. So you can go in and down this every quarter. As I say, it goes to the National Implementation Group for Radiotherapy. And there's a whole range of indicators in it, one around attendances per million population. But I think what for me is quite exciting is down at the bottom here. We've got this commentary that Tim Cooper from the Cancer Action Team and Peter Hoskins, who chairs our radiotherapy information group, write each quarter. They have the whole document and they look at what's happening over time, what's happened from the last quarter, and put their take on what we're doing for radiotherapy services. And I think we're going to look to be doing something similar for chemotherapy, and there may be other commissioning areas that lend themselves to having this sort of instant report, if you like, that's available to you, but with the underlying data in the toolkit. So you can then, as a local team, whether it's the networks, the commissioning groups, go in and actually see what does that mean for my service based on what the national groups are saying. So there's things around attendance per million, numbers of LINACs, the age one, which you saw, the interactive part of that, around service profiles. So this is around 31-day treatments for cancer waits, and then the clinical delivery by fractionation. So this data are all now in here. And this data is pulled interactively directly out of the toolkit. So as we get new data each quarter from cancer waits or from the team that manage the radiotherapy data, it goes straight into the toolkit and cascades straight through into here. I think I've done most of this. So I think I'll stop there and sort of ask people what, a number of you have been using the toolkit, but to give us some feedback around, is this moving in sort of the direction you think it should do? What other things might we want to do? How better can this toolkit really drive what you want? or how better could NCIN actually signpost you to data, and really anything else that you think we ought to be helping you to move forward over the next 2 or 3 years with supporting commissioning in the new landscape. And I'll stop there and if people have questions. Yes.
I know we don't have particularly good outcome data at the moment, but
Yeah.
that is the way we're trying to move is towards gathering good outcome data. Oh, I'm sure I can shout. Do you think the toolkit will be able to pick that up as it becomes more available? Because I think that would be really helpful. And really helpful for the commissioners, because they will then have to commission against improved outcomes.
Yes. I mean, I think one of the first questions I would always put back to you is, what do you actually mean by outcomes? Because you can have a number of dialogue with people and say, we want outcomes, and when you actually say, what do you mean by outcomes?
Well,
dead and alive
is the start. And then sort of shades of grey, you know, in between, yeah.
Yeah, I mean, in the profiles, those of you that have looked at the service profiles will see that there is a line in there which is looking at 1 year, 5-year survival by provider. Now, the reason we haven't done that is actually around the methodology to use that. There are a couple of issues for that. One is around actually linking a patient to an MDT. How do we know that patient was part of that service? Which might seem quite amazing that it's quite difficult to hook a patient on. But we're working out how we do that. So once we do that, then we'll know what the cohort is. But for some services, and even breast and colorectal fall foul of it, but when you start to move into the real specialist areas, for lung, they may be part of a local MDT, and then they may go to a thoracic surgeon. So as a commissioner, you probably want to see what's happening when they go to for the thoracic team, as well as seeing your local team. So we've got to work out how we hook patients onto those to be able to do it. The other side of it is then being able to case mix adjust. And how far do we case mix adjust? Because again, we know even if we can link the patients to a particular MDT, we've got to take allowance for things like stage, comorbidity, age maybe, as a minimum deprivation possibly. Because if we don't, the outlier trust will immediately say, my patients are older, sicker, they're different. So we've got to make sure we've got good methodology before we do that, because I think there's a real danger otherwise that we're sharing things that perhaps we're not quite comfortable with. So again, it's that publish and polish. We need to have a certain level of acceptance of the methodology. As soon as we've got that, that data will flow through here.